Thank you, Nicola, for the kind introduction, and I'm pleased to be here to present to you all on behalf of the FHSC. So it's well established that FH is a common condition with one person in every 311 individuals having FH. Now, this is the most comprehensive and contemporary estimate within the general population and was derived from over 7.3 million individuals. Based on the current population size in the European Union, there are potentially more than 1.4 million individuals with FH, and the estimates specific to countries within the European Union are shown on the map. So despite FH being a common condition, over 90% of those with FH are yet to be detected. So greater attention towards strategies to improve detection is warranted. And one of the key recommendations by the global FH community is the establishment of registries to understand the status of FH care worldwide and current practices and gaps so that we can begin to address these through data-driven approaches. But this is a visualization for illustrative purposes to highlight that whilst many initiatives on FH exist within and between countries, they largely operate in a siloed manner, and the lack of an integrated approach has so far limited the public health strategies to tackle the global burden. So to have an integrated approach, the FH Studies Collaboration, or FHSC for short, was initiated in 2015 to bring together a consortium of worldwide FH cohorts and registries with a view to promote early diagnosis and more effective treatment of FH. And currently we have 67 countries participating in this initiative. This is a busy slide, but what I want to bring to your attention is the process of how data from local sites within countries is collated by national investigators and is transferred to the FHSC data warehouse. In here, all received data undergoes multiple checks and validation processes in order to harmonize and standardize the data into a single format to be able to produce reliable quantitative metrics with greater precision. So this has led to our first publication from the FHSC cohort registry on the adult population. And from the available data, we can see that the median age of being diagnosed with FH is in the mid-40s. And from the bar graph of the proportion of participants in the registry, we can see that 40.2% are being diagnosed at ages less than 40 years, and only 2.1% are being diagnosed at ages less than 18 years. So detection in childhood is low, and diagnosis is occurring late in life. Now, these findings are important to illustrate that if FH is not identified at earliest time points, such as during childhood, then many years elapse before FH is detected, with missed opportunity of receiving appropriate treatment during these elapsed years. Now, this slide shows the prevalence of cardiovascular disease at entry into the registry. So when FH is detected, 1 in 6 adults have established cardiovascular disease, and in most cases, this is premature. We know that non-index cases identified through cascade screening are younger and have less risk factors. However, generally for cascade screening to be triggered, we are relying on an adult having a cardiovascular event in the first place in order to find others, i.e. the children within the families. Here we see that within the registry, less than 3% of adults taking lipid-lowering medication only 3% meet the guideline recommended goal attainment. So not only are individuals being identified late in life, but are also not reaching treatment goals. Also, as LDL-C is cumulative, this means that more aggressive treatment is required the later an individual is found due to the accumulation of atherosclerosis or hardening of blood vessels. But if we identify early through active screening, then we can have the benefit of prescribing less aggressive treatments at later time points in an individual's life. So from the current cohort within the registry of over 66,000 individuals, there are over 10,000 children that have been diagnosed with heterozygous FH. And I will now present some preliminary data of the children data set within the registry. As you can see from the bar graph, that over 75% of children have been diagnosed through a genetic test, which has been initiated as part of cascade screening. And to the right of your screen on the bar graph, we see that over 11% are index cases, which means that these 11% have been found systematically, for example, by their age group, and not through an event triggering the search. The majority, or 88%, are non-index cases and found via cascade screening as a result of their parent being diagnosed, most likely following a cardiovascular event. In this slide, we see the LDL cholesterol at entry into the registry for children, and we can see that the overall LDL-C is 196 milligrams per deciliter. This is very high considering the normal healthy range is less than 110 in those without FH. But this shows the importance of detecting early to initiate treatment at the beginning of the disease so that we can reduce the hardening of blood vessels or atherosclerosis, but also encourage healthy habits to enable a life course that is free of cardiovascular events. So given the current world population of 7 billion, there are between 25 to 35 million individuals with FH, of which more than 1.4 million are in the European Union. We have seen that diagnosis of FH is occurring late in life where cardiovascular disease is already established and is often the trigger for testing in children. We also see that children have high LDL-C from a young age but are not receiving treatment. Screening actively for FH in childhood has substantial public health benefits, not least because you can identify their parents before they have a cardiovascular event, but also that if we identify early, then we can treat early to reduce the LDL-C to a normal range and prevent development of atherosclerosis and enable a life course that mirrors the general population. These are my acknowledgements, and I thank you very much for listening.